over to you at chairpersons.
Welcome to our next session dealing with dual threats. First speaker, let us welcome Mrs. Jyoti Dhar.
ASICON welcomes Dr. Jyoti Dhar. Dr. Jyoti Dhar has over 24 years of experience as a consultant physician in Leicester, UK. Dr. Dhar is an expert in managing pregnant women with HIV, leading the largest cohort of such patients in the UK outside of London. She has served on the board of the British Association of Sexual Health and HIV and has held various regional and national advisory positions. Dr. Dhar is recognized for her contributions to medical education, having designed curricula and developed online learning tools. She is widely published and frequently invited to speak at national and international events and was conferred the title of Professor in Medical Education by the University of Leicester. We look to hear her talk on STI, Doxy Prep and Doxy Prep.
Thank you very much, everybody, and especially for being here. Thank you to the chair, and thank you to the organizing committee for giving me the opportunity to be here. This is going to be a slightly contentious discussion. Hopefully, by the end of the session, we'll have explored some of the current STI trends globally, but my focus will be primarily on England. We'll explore some of the prevention strategies that are in place at the moment, and also look at the challenges that are faced by clinicians in the implementation of these preventative strategies. I'm sure for this audience, I thought it would be a nice thing to do a little bit of an exercise, pen down of the four big bacterial and four viral infections globally, which of these STIs are increasing, decreasing, or are otherwise stable. And we'll come back to this towards the end of the session. Now, as I said, most of the surveillance data that I'll be talking about is the most recent surveillance data that has been provided for England. And if you look at the way the trends have been since from 2014 to 2019, STIs never went anywhere. They were there, always there. So when people talk about resurgence of STI, I think it's a fallacy. The reason why 2021, 2020, and 21 we had a drop, obviously, was COVID, okay? So everything went into lockdown. But as soon as COVID went, 2022, there was an upsurge. We had nearly 50% increase in STI diagnoses, a slightly smaller increase in 2023, and that's partially explained by the fact that in 2022 we were subjected to one of the most horrendous monkeypox outbreak, which lasted from May 2022 to December 2022, and sexual health services were inundated with monkeypox problems. So that probably reflects a different rate. Now, when we look at these STI rates post-COVID, whether you look at men or you look at women, it tells you the same story. A sharp dip and a sharp upsurge again. Whichever infections you look at, they're on their way up. But I just felt this is such important information, which was, I'm sure many of you were in the case studies yesterday, which tells you about the greatest mimicker. In 2023, when we looked at the rate of infectious syphilis diagnosis in England, it was seen that by gender and age, in men, the rates of infectious syphilis were 16 times higher among men when you compare them to women of the same age, okay? And it's less age-specific, meaning they're not concentrated where your normal STIs are, that are 16 to 24-year-olds for chlamydia, gonorrhea. So that means that there is the presence of this infection right through in men till the age of 60. I mean, yesterday's case was 70-plus gentlemen who presented with syphilis. So therefore, this is something that we all need to be aware of. What about gonorrhea? Again, interestingly, you can see the peak in women, which was much higher than the male peak, was less than 20. It was at the age of 20, whereas men tended to get gonorrhea slightly older at 20, about 29, 30. And again, there's a sharp decline in gonococcal infection in women after that, whereas in men, it took a little while longer, till about 50, 55 years to peter out. So that means it's there to stay and explains transmissibility. What about STIs in gay, bisexual MSMs? Looking at the data, you can see it's all up, except the COVID period. The only, here, this one, here, this is, can anybody say what that is? HIV, okay? So otherwise, they're all going up. Interestingly, when we look at the number of gonorrhea infections by gender and bisexual orientation, obviously the gay and bisexuals take the cake, basically. I mean, you can't compete with those rates. But not surprisingly, men and women, cisgender men and cisgender women, have almost similar rates of infection. Another important facet that 2023 gave us was repeat infections with gonorrhea. They looked at between the periods 2019 to 2023. As you can see, men who are having sex with men, obviously their rates of repeat infections are nearly 16%, but women are not far behind when it comes to competing with cisgender men. They have almost the same rates, so they get reinfected within a year period, and that again probably explains the transmissibility of gonococcal infection. What about trans? Not surprisingly, we've never recorded trans data and gender diverse groups in our surveillance studies, in our regular surveillance clinics. This was introduced in 2019. We were mandated to identify gender diverse groups, and by 2023, the data was complete. Okay, all clinics had adopted this coding, I think we were rewarded by this, because if you look at the gonorrhea and syphilis diagnosis in 2023 in the gender diverse transgender men, women, you can see that we are identifying infectivity rates in them now. What about people with HIV? Of the 3% of all STIs diagnosed globally in 2023, half were in MSMs with HIV. This is further borne out by the fact that the Swiss cohort showed us that when they looked at data that they analyzed over a 2-year period, which had a lot of participants, MSMs, about 35% had been identified as having new syphilis, and they'd had a new STI. Predominantly, those MSMs who were younger than 50 and comprised only 21% of the participants, 61% of them had an STI. That means very high infection rates. Syphilis, GC, CT was obviously quite high. Now, there's been an alarming decline in the use of condoms. It's been so alarming that the WHO came out with a statement in August 2024 saying something needs to be done about it. And it's the same thing happens in gay bisexuals as well, and also in our people living with HIV. And this is a study from the Lancet which shows that condomless anal sex was reported by 96% of people living with HIV, and 23% of them had detectable viremia. The factors I've just enumerated there for you to read. I'm not going to go through that. But what it identified is that condom use is still a myth, okay? It's not something that you can consider as a risk reduction behavior any longer. Interestingly, I'm delighted to share this slide with you, that even in the 21st century, in a high-income country, when we looked at the rates of STI diagnosis by the IMD score, which is the score for deprivation of poverty, basically, you can see here that the highest STIs were in areas in England which were the most deprived, which is not. So acknowledging the inequity in disease burden of STIs is paramount. So this leaves us with a burden. Unfortunately, what happens in the high-income group is the males that get affected, and in the low and middle-income group is the females that bear the brunt of STIs, and the conditions are mentioned there, and I won't go into those. So I thought, let's look at this burden of disease and what are the challenges that these prevention strategies bring us. Condoms, they don't work, risk reduction barrier, vaccinations. Interestingly, knowing your STI status and regular STIs testing is also a prevention strategy, okay? And that reminds me of your ex-president, Abul Kalam, who said, you cannot change your future, but you can change your habits, and surely your habits will change your future. I don't know how true or untrue this statement is. However, we do know that that doesn't work, because we need a biomedical intervention to reduce the burden of the disease, and that is prophylaxis with antibiotics to prevent STIs. It's a concept which we'll explore a little bit more. There are two elements to it, a pre-exposure arm and a post-exposure arm. In the pre-exposure arm, you use doxycycline 100 milligrams daily to prevent an STI. Does it prevent it? Yes. Studies have shown that if MSMs on doxyprep are given, or MSMs given doxyprep, when a group of MSMs given an incentive, money incentive, this can only happen in the States, money incentive to remain STI-free during a 48-week follow-up, they show response rates of 73%. They're less likely to get an STI. Australian modeling exercises have shown if you give half of the MSMs doxyprep, which has a 70% efficacy, it will decrease the syphilis rates by 50% in 1 year and 85% in a decade. That's magic. Again, the same modeling exercise has shown if we treat the highest risk group, that is men who have more than 20 partners in 6 months, and give them doxyprep, they'll have the same findings. What about post-exposure prophylaxis using doxycycline? That is, within 24 to 72 hours of sexual intercourse, the person takes doxypep. And there's been at least 3 randomized controlled trials which show that they work both in HIV negative as well as HIV positive patients, causing reduction significantly in STIs. But unfortunately, we didn't have any real-world data. That's all research. And there was a study in Glasgow, which was the PRIDOX study, and that showed, which was done in the real world, doxypep was given to MSMs and showed a significant decline in syphilis rates. And this was quite remarkable. Look at the number of infections. Pre-Doxy was 2.6, and post-Doxy it had gone down to 2.5. So it does work in syphilis. There are some caveats to this. Does it increase multi-drug resistance? It didn't show a huge, only 8.6%, and all the isolates were susceptible to ceftriaxone. So good news all over. When should doxypep be taken? It should be given as a single dose, 200 milligrams within and up to 72 hours, and no later than 72 hours. No other antibiotic should be used. Any other use of antibiotics should be strongly discouraged. This is something that you do need to take away from this talk today. We know from a UK survey that MSMs have been using amoxicillin, Cetrin, ciprofloxacin as doxypep, which is wrong. Avoid multiple doses, even if they have multiple partners. Say over the weekend they have partners, tell them they don't need to take anything till the Monday morning, and that's only 1 dose. The maximum dose they can take in a week is 200 milligrams 3 times a day. Obviously, when you prescribe it, you will discuss side effects of doxycycline. And doxycycline is the only drug that should be used. Who could benefit from doxypep? The CDC recommends, as part of a comprehensive holistic sexual health package, discuss with those who would benefit the most. And so far, the evidence is that it's only effective in gay, bisexual, MSMs, and transgender women who have had a bacterial STI in the last year. So identifying those individuals and offering them Doxy-PEP will be the way forward. If you identify and they qualify, offer it to them, prescribe it, and they can self-administer it. It may be useful in cisgender men who have had condomless sex with a woman, could be their wife, could be a partner, could be a girlfriend, and more than one partner. If we in the UK think, and I've added it here, that there is a mental health benefit to giving Doxy-PEP to a worried, well person who's really worried, doesn't qualify in that, maybe you should give it to them. There's a lack of data in transgender and queer and non-binary and should not be given. What about in cisgender women? All up in the air. Very poor showing from the only cisgender trial which was done in Kenya. There's insufficient evidence at the moment to suggest that it is of any benefit at all. The reasoning was given that probably the adherence to doxycycline was very poor in this group, as we have seen in oral PrEP, because pharmacokinetically, doxycycline is as effective in females as it is in men, with probably higher concentrations in the rectum as compared to men. However, there is a global dissent on Doxy-PEP, and this is because of tetracycline resistance. Prafti did a wonderful presentation the other day on AMR, so I don't need to talk about it. However, there is the main reason for dissent is that benefit afforded by Doxy-PEP for people who are assigned male at birth may not outweigh the risks associated with AMR. Food for thought. And the reasons are this: emerging resistance to Mycoplasma genitalium and gonorrhea. Our consultative process has started. It will complete in the UK at the end of March, and hopefully, but we are prescribing it only to prevent syphilis, nothing else. So, to prevent 1.3 bacterial STI every year, on an average, you will have to dish out about 43 doses of Doxy-PEP. Think about it. So there are certain concerns for use of Doxy-PEP in India. Largest manufacturer consumer, unregulated prescribing. There's limited testing and monitoring. There is a huge tetracycline resistance, and it may compromise some of the NACO regimens that are currently in use for azithromycin cathexin, and that is a bit of a concern for for all of you. Now, as I said, STI, knowing your STI status and regular STI testing is also a prevention strategy, and I thought it was imperative for me to explore that a little bit. Now, we do STI testing for what? To identify infection, and it is important. And why we do that is because we deal with HIV positive patients. We are in a unique position to offer preventative care. So what do? We recommend screening for STI, syphilis serology, and we do NAT testing in all high-income countries with nucleic acid amplification testing, and we do extra swabs depending on the sites of exposure. Okay, so is it happening globally? Not really, because only STI screening is only happening in about 15% of HIV care settings. But I want you to take this with you. Overall, 51% of STI cases in people with HIV are symptom-free. Okay? So does asymptomatic infection matter when in this group of individuals when it's self-limiting? What do I mean by that? If we look at gonorrhea rates, okay, rectal and throat gonorrhea, okay, asymptomatic 85% of your people who have rectal and throat gonorrhea are asymptomatic, and this will clear by itself without any medication within a period of 9 weeks to 16 weeks. Okay, take chlamydia. Nearly all of throat infections are asymptomatic. More than 65% of your rectal infections are asymptomatic. Small caveat, urethral infections, about 50% are asymptomatic. And again, this will clear within 9 to 13 weeks. So it raises a question, is asymptomatic testing for STIs necessary? This is one end of the spectrum. The other end of the spectrum, which I saw yesterday with some posters yesterday, is the testing that we currently do in India fit for purpose? Is it any good? We do syndromic case management, which has remained the cornerstone of treatment. It performs well for vaginal, but you only identify 5% of your women with chlamydia. There is no etiological approach, there is no molecular assay, and it leads to overtreatment. But the most important thing is it does not interrupt transmission, and that is the cornerstone of what I'm talking about. So it creates a challenge for all of you. How do you inform treatment guidelines? You have no susceptibility patterns. I mean, how do you address this? And how can you even think of pre- and post-exposure STI prophylaxis? So Doxy PEP is transformational, but impermanent prevention strategy, and that should be borne in mind. So coming back to my first question, I don't know how many of you have got the right answers. So the current global trends in STI are increasing for chlamydia, syphilis, gonorrhea, stable for genital herpes and trichomonas, and decreasing for HIV and genital warts. Thank you for your listening.
Thank you very much for this fantastic talk. All answers will be taken at the end of the session. And the next speaker, let us welcome Dr.
Satish Rao talk on Association of HIV and TB, which we all of you know is a global challenge. So we welcome Dr. Satish Rao.
Good morning to all of you. At the outset, let me thank Dr. Gilada and his entire team of ASICON 2025 for organizing it. I'm going to speak on HIV and TB and new strategies. My talk involves something which is already published and some ideas for future. So this is a brief outline of the talk. I'll first discuss some data, recent data, and then I'll move on to the diagnostics, and then finally I'll discuss some treatment strategies. This appeared in New England Journal of Medicine 2024 article, and this is based on CAPRISA model based on 30 years data from South Africa. The trends are very clear. With the introduction of ART, the trends have drastically changed, bringing down the incidence of tuberculosis and incidence of tuberculosis associated deaths. But the point that I want to highlight is the numbers still continue to remain high when compared to 1990s. This is a global snapshot of HIV TB. I don't want to spend too much time on this. What I want to highlight is TB is still the major killer as far as HIV is concerned. And in 2022, only 54% of patients with dual infection received both TB and ART. So this number needs to go up. And between 2010 and 2022, 6.4 million deaths were prevented by just treating tuberculosis and then ART. But then the COVID impacted us badly. For the first time since 26, the TB death rates among PLHIV went up, and then this resulted in UNAIDS declaring this as an emergency on the World Tuberculosis Day 2022. If you look at the NTB strategy roadmap, we are supposed to, the reduction in number of TB deaths should be by about 90% and reduction in TB incidence rates by about 80% by 2030. And this is the roadmap which is supposed to lead us to those targets by optimum utilization of the available resources and also development of new preventive tools and other treatment strategies. The NTB strategy stands on 3 pillars. I'm not going to spend time on all this. I'll focus only on pillar 3, which is aimed at intensified research and innovation. In a study published, in a review published by Mangalore et al., all these possible new approaches for HIV-TB was discussed, and the approach could be in the form of new TB diagnostics like the rapid point of care test, and then it could be in the form of new treatment for drug-resistant tuberculosis, or it could be some new approaches related to ART in low and middle income countries, and then it could be in the form of some novel approaches like something like host-directed therapies, or then interventions related to reducing the drug toxicity in these patients. I discussed some of these, not all. First, I will take up urinary lamp test. WHO has given clear recommendations when we need to do the test. In OPD setting, if somebody has signs and symptoms of tuberculosis or is seriously ill, they need to be tested with urinary lamp. Similarly, if the CD4 cell count is below 100, irrespective of signs and symptoms of TB, they need to be tested. In an inpatient setting, if anybody is admitted for signs and symptoms evaluation of tuberculosis, they need to be tested. At the same time, if somebody is having advanced HIV disease and is seriously ill, also needs to be tested. WHO has also told us when not to do the testing. This applies to OPD setting, where if you have not done enough assessment of TB symptoms, or if somebody doesn't have TB symptoms with unknown CD4 cell count, or a CD4 cell count which is above 100, we need not test those patients. What is this urinary lamp? When the mycobacteria degrades, the lipoarabinomalum is released into the circulation, and this eventually reaches kidney, is filtered in the glomerulus, and it appears in the urine. Presence of LAM in the urine indicates either disseminated tuberculosis or presence of renal tuberculosis. And as of now, we have only one test, which is LRI-LAM test, which is approved by WHO for commercial use, but it has got a lot of performance-related issues. It suffers from low sensitivity, which is just about 42%, and it has got a specificity of about 80%. Why this happens? Even the second generation test, which is supposed to be better than this, in Fuji LAM test, also suffers or has same problems. Like it has a sensitivity of about 70%, but specificity is near 90%. But there is a big bottleneck, which I will discuss shortly. If you look at the sensitivity, specificity of all these tests, it varies. Why it varies? Because of 3 things. One, all these are tested, or these are tested against the standard, gold standard of culture, which itself is not definitive. And then, depending on how much the bacillary load in the various samples that you have collected to do the test, that also has an impact on the performance of the test. And then the immune status of an individual also plays an important role. This we all know that in tuberculosis and HIV, depending on the immune status, supposing the CD4 cell count is good, the tuberculosis behaves in a typical fashion. If the CD4 cell count is low, the risk of extrapulmonary tuberculosis and atypical manifestation increase. And this is also one of the reasons why these tests suffer in their performance. So how to overcome these barriers? Probably we can take an opposite approach. Try to develop a test in non-HIV population, develop it, and then take it to HIV population rather than doing it the other way around. And then try to develop some tests which are innovative tests based on new technologies or next generation LAM tests, like one which is shown here. This test is based on quantum dot nano based probes, which are highly efficient probes. And as you can see here, this test, reading of this happens using a portable reader. Now, if you go to Fuji LAM, the last part of it, that is the interpretation, is based on a human interpretation, which could be very subjective and leads to a lot of confusion. That part also has been overcome in this by introducing a portable reader. And this particular test has been done in non-HIV population with a sensitivity of about 52% and specificity of 96% and the error rate of just about 0.6%, which is way less than Fuji-Lam test, which is about 2%. The other approach could be like combining these tests. This has been shown by Govt et al. In non-HIV population in patients with pulmonary tuberculosis and extrapulmonary tuberculosis, and the same author has also done a cost analysis of this and shown that this is cost effective. And finally, in this, focused assessment with sonography for HIV associated tuberculosis, in short FASH, was developed way back in 2012 in Africa to diagnose extrapulmonary tuberculosis using a 6-point ultrasound technique wherein, based on presence or absence of pericardial effusion, pleural effusion, ascites, splenic granulomas, liver abscess, and pre-para-aortic lymphadenopathy, it was supposed to be used in peripheral hospitals where high-end imaging modalities are not available. This was tested in a study. It was a randomized controlled parallel superiority open label trial, but the outcomes were not very promising. It just said there was no significant contribution by this new technique in adding value to the TB treatment in HIV and also non-HIV patients. So then, this is about the investigations. Now we'll go on to some treatment strategies. Wherever I put question mark, it means it has not been tested in HIV population, but tested in non-HIV population. First in that is, can we reduce the duration of treatment? Reducing duration of treatment will reduce the cost, reduce drug interaction, reduce drug toxicity, improve compliance. So, do we have anything here? A recently published study, which is in an HIV, non-HIV population, is rifampicin susceptible tuberculosis. It's a comparison between a standard 6 months therapy with two novel regimes involving either rifampicin and linezolid or bedaquiline and linezolid with isoniazid, pyrazinamide and ethambutol. When they assess the outcomes at the end of 96 weeks, bedaquiline and linezolid performed as equal to standard treatment, and the adverse effect profile was also more or less same. And the authors concluded that bedaquiline linezolid based regime is non-inferior to rifampicin based regime. At the same time, WHO also upgraded its recommendations, where it said 6 months treatment regime composed of bedaquiline, pretonamide, linezolid and moxifloxacin should be used rather than 9 months or longer regimes for MDR TB and rifampicin resistant tuberculosis. Now the moxifloxacin to be used based on the presence or absence of fluoroquinone resistance. So this has been tested in non-HIV population, but probably one approach that could be tried in at least those patients who are on stable ART. The next approach is empirical TB treatment at ART initiation. There are 3 main trials in this: the TB fast track trial, Remember trial, and Status ARNS trial. And all these trials, they looked at patients who were initiated on empirical ATT when there was nothing suggestive of tuberculosis or no investigation pointing toward, with ART, and another arm only ART. And they looked at the outcome at 24 and 48 weeks to see whether the mortality benefit is there or not there, whether the risk of infection is. But unfortunately, none of these studies had any positive outcome attributed to adverse effects related to ATT. And this particular study, Status, this was accompanied by an editorial, and the editor felt this could be an attempt where there is too much done and too little comes out. So this is sort of a final nail in the coffin of this concept. Next, going on, repurposing of drugs with known safety profile. Now, there are 2 examples here. One is with linezolid, the other one with clofazimine. In this study done on HIV, non-HIV population, with a combination of bedaquiline, pretonamide and linezolid. If you see the 4 arms, there were 2 arms with 26 weeks, 2 arms with 9 weeks, and two dosages of linezolid, 1200 mg and 600 mg. Almost all the arms had a favorable outcome, but the overall risk-benefit ratio favored the group that received the 3-drug regime with linezolid at a dose of 600 mg for 26 weeks, with a lower incidence of adverse events reported and fewer linked dose modifications. Since this is an Indian study, ICMR sponsored, and clofazimine in combination with bedaquiline, delamanid, and linezolid, and this also had a favorable outcome. Probably this kind of repurposing of drugs can also be used to plan newer regimes for tuberculosis in HIV. Then next, moving on to the new integrase inhibitor based treatment. This was presented in recent drawing in 2024, where double dose bictegravir was compared with double dose dolutegravir in patients who are on rifampicin based also be used in patients who are on treatment for tuberculosis. This is another interesting study I found, where double dose dolutegravir were compared with single dose dolutegravir in patients who are on ADT with rifampicin, and the authors felt DTG may not be necessary in PLHIV with tuberculosis. So this I did not find much. The role of midcanin vitamin B to reduce ADT-related urinary host-directed therapies like rapamycin, vitamin D also have been used to modulate immunity, and also it has been demonstrated to have some role in treatment of iris. This is a study you can go and refer if you are interested. And finally, TB prevention. These are the recommended combinations which was there in a very good review article which all of you should read in New England Journal of Medicine. And this, you have all these combinations with INH and rifampicin, or INH or rifampicin used as single drug. And the last slide in this is another latest study which came recently, where in Vietnam they used levofloxacin to prevent multi-drug resistant tuberculosis. In this study only 8 HIV patients were there, and here the incidence of TB was lower in the levofloxacin group than in the placebo group at 30 months. However, the difference was not statistically significant. And to summarize, scaling up of simple, rapid and sensitive TB diagnostics have promoted early access to TB treatment by PLHIV. New and repurposed TB drugs have transformed the treatment of drug-resistant HIV-associated TB, particularly MDR and STR TB, enhancing the potency and reducing the toxicity. Integrase inhibitor-based ERT is effective and well tolerated by PLHIV receiving rifampicin-based TB treatment in resource-limited settings. Host-directed therapies as adjunct therapeutic approaches to augment antimicrobial TB treatment and improve treatment outcome needs further exploration. Thank you.
So, thank you very much for this nice talk. The next speaker is Dr. Gupta, talking about why CD4 matters.
It was done yesterday, so we can.
That was done.
So then, there are only 2 speakers for this session,
Yes.
right? Okay, then we open the session for few questions and answers. I would like to first of all ask Dr. Rao a question. That you said the TB co-infection should not be used in the as per the WHO guidelines. But as far as I know, NACO recommends screening for pulmonary tuberculosis in all newly diagnosed HIV patients. So,
that was only with reference to urinary lamp test.
Okay.
Urinary lamp test.
Any questions?
My question is to Dr. Jyoti Dhar regarding Doxy PEP. It has been globally recognized that 200 milligram capsules of doxycycline prevents 80% of syphilis and chlamydia and around 40 to 50% of gonorrhea. There is no harm in giving, because when the person is exposed and comes to us, we provide a combination prevention. We give them PEP for HIV. If they are not vaccinated against hepatitis B, we start rapid course of hepatitis B, and we give them 2 single dose of doxycycline. The problem is happening is, if you write, they buy 10 tablets. Nowhere 2 tablets are available. And they say, sir, pada tha to kha liya. So that might cause resistance. So what we do from our clinic is we provide them 2 tablets of doxycycline free of charge, because it doesn't cost much. So I think there is a benefit of doxycycline. We cannot say that it doesn't benefit, so we should not be sharing. That is one thing. And the comment on TB, urinary lamp is not available in practice. It is available only in program. And last 4 or 5 years it has been decided that urinary lamp is a very simple test for latent tuberculosis, should be made available to everybody. It has been, I think, Dr. Sachdeva was there on the TB committee. I was one of that latent TB committee there. I don't know where is a hitch. Why simple test which is available to be done on urine is not made available to practitioners, clinicians. So there is some problem, and that needs to be solved. If it is available for research, if it is available in the program, why not to us?
Thank you, Ishabhai. I totally agree with you, but why just give them 1 dose? Why not give them more than 1 dose? So you're telling them just have one in sexual encounter. So on prescription, sex on prescription. Sorry, I'm being facetious. I mean, I'm sure. I mean, it's not a problem. But we do know that the tetracycline resistant in India is sky high. So unless you're monitoring, you're doing some monitoring on a large scale, advocating something like that, I think is a bit of a problem. The other problem is there is a fear. It's not been borne out yet. There's a fear that the serological response to syphilis by the use of doxycycline is going to be something different. I mean, it's not been borne out yet in studies, but that is another major concern, that doxycycline, which is very useful in syphilis, may be compromised. So I agree with you. I'm not saying don't give them.
For treatment in syphilis is not useful. Erythromycin in syphilis is not useful.
That's what I'm saying.
Ma'am, what should be the duration for it?
Sorry.
May I hear here behind you? What should be the duration? How long we can continue the doxy?
As long as he's having sex.
So it should
If
be
he
there
feels-
always.
See, it's like you have to educate your patient. If he's having sex with his wife, okay, all right. So obviously he thinks she's monogamous, and he may not want to take it. But if he has another partner and he wants to have condomless sex with, say, a female sex worker, for instance, so it's that conversation that you need to have with your patient, and he or she should have implicit trust in your judgment. Whereas in India, there is a secondopinion.com. I mean, everybody wants a second opinion. Nobody trusts the doctor. So it's that conversation. I'm not saying you shouldn't use it, but I'm saying it needs to be used judiciously. That's what I'm saying.
Thank you, Dr.
Is that right, Christoph?
So, thank you, Jyoti. I can share some experiences. I have one question as well. So in my clinic, we see mainly MSM patients, and the majority of them, let's say 1/3, requested ever on doxycycline, because the education in the peer group of gay men and MSM community is far high. We have several patients, once we get into detailed discussion with them, reporting their last chlamydia treatment, where we prescribed 20 tablets of doxycycline. That takes 7 days, because they know 7 days for uncomplicated chlamydia infection is far enough, and then they have 3 more shots to have condomless intercourse. So what we do is, what Jyoti says, we educate our patients, offer them treatment education on how to use doxycycline, and we also educate them, I mean, at maximum, once, let's hypothesize, they have sex every other day with a random partner, it means they need to take 3 courses a week, which is, in the end, doxyprep, and that is part of my question. You elaborated nicely the data on doxyprep that could be debated on a case-by-case discussion at the current European guidelines, but how about doxyprep? So what is once a patient come and ask on a once daily taking 100 milligram, which is doxyprep, which is different from doxyprep?
It's not yet been adopted in clinical guidelines. There is a research ongoing of the use of pre-exposure prophylaxis for doxycycline. So at the moment, I'd say there isn't enough evidence. There will be evidence over the next year or two. Hopefully, we can share that with you. But at the moment, clinically, the doxypep can be utilized, but not doxyprep. And saying that, again, this comes to education. I mean, we realized that some of our MSMs were taking antibiotics, that were totally useless. They were on antibiotics because somebody had mentioned, I'm taking to prevent syphilis or whatever. Totally. So therefore, this conversation, that you need that conversation with your, we don't call them high risk, we call them at risk individuals. And that's for you to identify. Sorry.
Thank you, Dr. Jyoti. And you showed some very nice data, but I presume that the PrEP and PEP demarcation is not very stringent here as far as the doxy is concerned.
It is. I mean, one is taken before the sexual encounter.
Yeah, but how can you yourself say that how can you be sure that he is going to be sexually active next day or not? So,
as long as he's got it. So, for instance, I plan having sex on a Friday, okay? So I know I'm having sex on a Friday. I can take it up to 72 hours. So it's not that I've got to, swallow a pill straight away. It will, the effect, within and up to 72 hours. That's why I put it in bold, and not after that. So the protection, the protective effect is up to 72 hours. So you need to take your tablets within that period, time frame.
Yeah, but he is not going to stop having it after 72 hours. Maybe the next encounter.
So that's why the maximum dose that you can. So if you're talking about they're having sex 3 times a week, as Christoph's mentioned, so the maximum that you can provide and should tell them is that they should look at taking a maximum dose 3 times a week. That's okay. And that will provide them with, and it more or less lands up, as Christoph was saying, as being like pre-exposure. It's almost, so there is, I can understand what you mean, but there is very little, distinction between the two. But that's not something that you would advocate. That's what I'm saying. It's not something that you would advocate your patient to do. You, as a clinician, have to stick with it, saying that this is post-exposure, not pre-exposure, because there isn't any clinical data yet for its efficacy. Yeah.
Thank you. And Dr. Karthik wanted to, I think, share some information.
Ma'am, I want to give some update. I don't know whether this crowd is knowing about it or not. First thing is, madam, I just did about 56 verbal autopsies of TB deaths about 2 months back. So in that I found that if 10 patients of tuberculosis died, out of that 2 patients are HIV positive. So it is very necessary that HIV TB co-infection should be detected earlier. I have seen that the patients detected in a month, and with TB and with HIV they died within a month. So it is happening a lot many times.
Yes, I agree.
Second update is, madam, B-bulk M regimen has already been started in our setup, and this is being provided by nodal DRDB centers. So at our district DB center in BJ Medical College also, we are giving them. So if any patient needs that, we can give them, because pretomanid and delamanid is still yet not available in the market. And delamanid costs 1.12 lakh, about 1.25 lakh per therapy for 6 months. So pretomanid is more costlier, and even bedaquiline at present it is costing around 25,000 rupees, and it is freely available at our setup. So any HIV positive patient can get that.
I am aware the bedaquiline pilot studies also started in BJMC also.
Yes,
and I was there. There for 10 years as program director.
So BPM is there in our setup.
It's not,
Third one is about TPD, tuberculosis preventive treatment. At present, for HIV positive patients, it is 1 HB, 1 month isoniazid with rifampicin, 300 plus 600 milligram. It is also available, and we are giving to all patients in BJ Medical College as well as other medical colleges. And the last one is about that test. At present, we are giving CYTB test, Cyrus test, that is as per Mendo's test, and we are testing the patients. Lab urine is not available in our program. It might have been costly or some problem might have been there, but CYTB is available at present. That our physicians can use from government setup for detecting latent TB or whether TBD is needed or not. That is it. Thank you, madam.
Thank you very much. And now I think we close this session. Yeah, thank you. Thank you all the speakers.
Thank you very much.